All right. Thanks very much, everybody. Thanks for the privilege of the podium today. We're going to talk about the management of obstructing colorectal cancer, something that I'm faced with not too infrequently at my institution. I have no disclosures. So, in introduction, colorectal cancer accounts for just about 1/2 of all large bowel obstructions, and about 10% of all colorectal cancers will present as a large bowel obstruction. Other causes, which we have been hearing about today, can often be difficult to distinguish, both clinically and radiographically. And the onset is insidious, depending on where the lesion is, can present with progressive constipation, narrowed stools, bright red bleeding per rectum, of course, crampy abdominal pain, more if it's on the right side. The presentation itself is variable and certainly can represent a surgical emergency. Typically, or the most common location is the sigmoid colon. 75% of these tumors are located distal to the splenic flexure when they present, and if there is associated perforation, 70% of the time it'll be at the level of the tumor, and 30% of the time it'll be more proximal. When it is proximal, typically these are the patients that present with diffuse peritonitis and sometimes shock, as opposed to the 70% at the level of the tumor. The contamination is often localized. The competency of the ileocecal valve is critical, and with a competent valve, you get a closed loop obstruction, which of course mandates immediate attention. And so real quick about emergent management, I'm not telling anybody here probably things they don't know, but this is certainly determined by the clinical condition of the patient and the acuity of the presentation. These folks should get evaluated with blood work and an upright x-ray. And if there are concerns for ischemia with free air and diffuse peritonitis or sepsis, these people should get aggressive resuscitation with IV fluids, potentially an NG tube, antibiotics, and of course a trip to the operating theater. So what happens when you're there? If you identify a right-sided lesion, of course your first mandate is sepsis control. And then if the lesion itself is resectable, we suggest a right colectomy and an endoleostomy. Certainly trying to adhere to oncologic principles if the condition warrants. You can do a couple of things with that distal colon limb, either bring it up as a mucus fistula or potentially a long Hartmann's. And then if the patient is severely unstable or if the disease is unresectable, then proximal diversion with a loop ileostomy, or if you can, depending on the level of the lesion, a loop colostomy. If the lesion is identified on the left side, again, sepsis control, and then we recommend a Hartmann's procedure if the lesion itself is resectable, following oncologic principles. We've talked about what to do with that distal sort of rectosigmoid bowel that either can bring it up through the fascia or potentially leave a drain. However, in these folks, you really have to look at the proximal colon. If there's a large cecal rent or something that you identify proximal injury, then a subtotal colectomy with endoleostomy is recommended. And again, if they are severely unstable or if the disease itself is unresectable, just proximal diversion. If the management is non-emergent and you have a little bit more time, then the CT scan is the imaging modality of choice. It can pick up on synchronous lesions, extrinsic disease, presence of a closed loop obstruction, or potentially metastatic disease. I like to obtain a water-soluble contrast enema if the lesion is on the left side, which gives me insight into the role of endoscopic stenting, kind of showing me the length and the severity of the stricture itself. So for right-sided lesions, again, this is more urgent or non-emergent management. Again, if the lesion is resectable, following oncologic principles, considering a primary anastomosis in these patients, leak rates are acceptable at between 2.5 and 5.2%, depending on what you read. Certainly a little bit higher than a normal right colectomy, but again, acceptable. Always take into account what these patients are going to need postoperatively. So again, for an obstructed or perforated colon cancer, they are potentially candidates for postoperative chemotherapy. If the lesion itself is unresectable, there are people doing some stents for right-sided lesions. That's more small case series, considering bowel bypass, or again, diversion with a loop ileostomy or colostomy. And in these patients, you can consider minimally invasive surgery. Again, these are selected patients, and then depending upon the surgeon, whether or not they're comfortable. The left side is a little bit more controversial. We suggest endoscopy if you can, and that's always with CO2, and that's really to gain tissue diagnosis. Operative management will go through, and then we'll briefly touch on self-expandable metallic stents. So, stent placement. We all know that emergency management of colorectal cancer confers poor oncologic outcomes and significant morbidity and mortality. So a stent can sometimes offer a bridge to surgery and palliation as well. We're going to really just touch on bridge to surgery here. Can allow for minimally invasive surgery, elective resection with a prep, evaluation of the proximal colon, and give you time to nutritionally and medically optimize the patient. They, of course, have their known complications, failure, migration, reobstruction, and then most studies suggest about a median risk of 4.5% to 5% of stent perforations. Sometimes these are silent, and sometimes they are at the site of the stent itself or the site of the tumor, or potentially proximal. And then again, there's caution with the use of stents if the patient is either on Avastin or planning on being treated with Avastin in the adjuvant setting. This patient of mine had a pretty tight left colon stricture at the level of the pelvic inlet. We stented her and resected her in 10 days. She did really well. So when it works well, it works well. But the data on long-term and oncologic outcomes is a little unclear. There's concern about whether or not the stent itself provides a radial force which allows for tumor dissemination into the lymphatics or bloodstream. And this is a systematic review of all the randomized controlled trials, which demonstrated a decreased short-term morbidity, lower rates of temporary and permanent stoma formation, but the analysis of tumor recurrence rates raises concern about oncologic safety for these patients. So if your institution does not have that availability, or if you're not comfortable, then you're heading to the operating room. If the lesion itself is above the peritoneal reflection and it's resectable, we suggest en bloc resection with oncologic principles. Again, considering a primary anastomosis in these patients, surgeon experience and the patient itself, whether or not they're a good candidate for that is very individualized. With or without proximal diversion, of course, again, up to the surgeon's discretion. In these obstructed patients, mortality and anastomotic leak rates are again higher, but acceptable. The safe procedure here is, again, the Hartman's procedure. And of course, you have to evaluate the proximal colon for gross injury or synchronous pathology, potentially requiring subtotal colectomy. For unresectable lesions at the time, or those lesions, low rectal cancers or extraperitoneal lesions, we suggest proximal diversion. In my hands, this is oftentimes a loop transverse colostomy or potentially even a blowhole, as described by Dr. Turnbull, and this is a paper from Dr. Paquette's team at Cincinnati. Sometimes this is very easy to do, bringing up the colon straight through the abdominal wall based on CT imaging. This allows for neoadjuvant treatment and, again, avoids risk to the marginal arcade and potentially disrupting your future anastomosis as opposed to like a sigmoid colostomy. So in conclusion, emergent management of obstructing colorectal cancer, certainly your first charge is sepsis control and resection with oncologic principles, likely, and again in my hands, an endoileostomy or colostomy formation. If you have a little bit more time, again, resection with oncologic principles, considering a primary anastomosis in these patients with or without fecal diversion. If your center has an adequate volume and experience of stent placement, you can consider stents as a bridge to surgery with a short interval resection, and then loop transverse colostomies or potentially a blowhole for those extraperitoneal lesions and rectal cancers. Again, always considering the need for adjuvant therapy in my management decisions. I'm often a little bit more cautious knowing that they need to be placed on chemotherapy pretty quickly. My references. Thank you.